for coming. I want to welcome Nan Rothrock, who is here from the Outcomes Measurement and Survey Corps. So welcome. Thank you.
Oh, thank you. As Sarah said, I'm Nan Rothrock. I'm a professor in medical social sciences. I'm the director of the Outcomes Measurement and Survey Corps, and I'm also a clinical psychologist in the supportive oncology team at the Cancer Center. I want to talk today about patient-reported outcome measures in cancer research. I have nothing to disclose. My plan for today is to provide a little history of patient-reported outcomes in cancer research, give some examples from recent clinical trials, and then share resources that are available to you for integrating patient-reported outcomes in your work. So let's get started with a definition. Patient-reported outcomes are any report of the status of a patient's health condition that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. And patient-reported outcomes cover a lot of really important aspects of health. They cover a number of symptoms like pain, fatigue, anxiety, functional status. Most commonly, we see physical function. Some of the more adaptive areas of health, positive affect, meaning and purpose, life satisfaction, and then also these intermediary or process constructs like self-efficacy for managing a condition, for example, and expectations, as well as this global term that we hear, health-related quality of life. So patient-reported outcome measurement really began probably in the 1950s. There were a number of studies about the psychosocial impact of cancer that got published. In the 1960s, we heard this term quality of life for the first time in this essay submitted to Eisenhower's Presidential Commission on National Goals, a society which puts a value on the quality of its national life will want to act resolutely. And then in the 80s, there was a sudden increase in publications using this term quality of life, as well as including fatigue and pain in cancer research. In the 1990s, there started to become an interest in standardizing and taking a more systematic approach to how we measure these things, particularly differences in definitions. So quality of life being the big one. Everybody knows what it is. Everybody has a different definition and includes different things for it. And there was also a recognition that there was really insufficient information about the measures that were being used to monitor these things. So in the 1990s, there were a number of policy recommendations that came about to try to improve quality of life assessment in cancer clinical trials. Here are some of these articles. Carol Moynipour leading one, Carolyn Gauthier leading another. Both of these are luminaries in the field. And then in 1992, the journal Quality of Life Research was first established, and the society that runs that journal and the big national or the International Conference on Quality of Life Research. The mission of ISAQUAL is to advance the scientific study of health-related quality of life and other patient-centered outcomes to identify effective interventions, enhance the quality of healthcare, and promote the health of populations. In 1997, the FDA came out in their Modernization Act and said, we really need to increase attention on health-related quality of life. This is an aspect of interventions that's not being addressed sufficiently. And then in 2009, they distributed a guidance for patient-reported outcome measures to support label claims. So if you have a drug trial or some kind of medical device and you want a label claim that says this reduces fatigue or reduces pain, the FDA is saying you have to follow this guidance for how you measure those things. The 21st Century Cures Act also includes a component of patient-reported outcome research. It's got a section, patient-focused drug development, that says all new drug approvals have to include a statement summarizing patient experience data that was submitted and reviewed as part of the application. What is patient experience data? Well, that's data collected by any person. So it could be the patient, it could also be a caregiver, a family member, patient advocacy organizations, disease research foundations, researchers, drug manufacturers, that's intended to provide information about patients' experiences with a disease or condition. And that data should include the impact of the disease or condition or a related therapy on patients' lives, and patients' preferences with respect to treatment of the disease or condition. So that first bullet really is best measured by patient-reported outcome measures. Patients are the best source of information for how their disease or treatment is impacting their life. So then the FDA kind of got really excited about guidance and distributed these 5 guidance documents. So guidance on collecting comprehensive and representative input, incorporating clinical outcome assessments, and those include patient-reported outcome measures, into endpoints for regulatory decision-making, methods to identify what is important to patients, how to select, develop, or modify a fit-for-purpose clinical outcome assessment, and then there's also, particular to cancer, patient-reported outcomes specifically for cancer clinical trials. And in that document, the FDA is recommending assessing symptomatic adverse events, side effect impact, role function, and pain, and to measure all of those by a patient report of those things. The FDA also notes additional pros that are important to patients outside of these core concepts could be prospectively specified and collected in trials based on the context of a given trial. So if there's one particular side effect that is critical to understand in a given intervention, then a measure for that can be included, with the caution that you should be carefully considered to minimize patient burden and improve the quality of data collection by focusing on the most meaningful and measurable outcomes. So not asking patients to spend lots of time completing measures of things that might be interesting, but to focus on what's most meaningful and what can be measured. So the impact of this statement can be shown by new drugs that have label claims from patient-reported outcome measures. So we see in this first bar from 2006 to 2015, about 20% of new drugs had label claims related to a patient-reported outcome measure, and that's increased to 26% since the 21st Century Cures Act. And then we can also look at how does oncology compare with other conditions. So this is a graph. On the x-axis are years, on the y-axis are the percent of drugs with PRO claims in oncology relative to all other approved drugs. And the light blue is the European Medicines Agency, which is the equivalent of the FDA in Europe. And so what you can note is in Europe, the number of oncology drugs with label claims really spiked beginning in 2010 and is much higher than it is in the US. In the United States, there's been some increase, but compared with when you compare oncology to other health conditions, it is not the majority. So the FDA does provide a helpful roadmap, given that they're stating patient-reported outcomes should be included in clinical trials. They give a nice roadmap for how you figure out what to include. It starts on the left in red with understanding the disease or condition. So understanding the patient or caregiver's perspective, the natural history of the disease, other factors like the healthcare environment or other input from providers. The next step then is to identify concepts of interest, such as how the patient feels, functions, or survives, and then to define the context of use. Once you know those two things, then it's really a review of, well, what measures exist, how well are they supported for this specific context of use, and do we need to modify it or actually develop a new measure in order to have a clinical outcome assessment that is fit for this specific trial. So that's a lot to go through. One tool that the FDA has to try to help this process is the qualification of drug development tools. So this is a process where you evaluate, well, let me start with a DDT. A drug development tool is a method, material, or measure that has potential to facilitate drug development. So we're thinking specifically about patient-reported outcome measures in this case. And qualification is a determination that that DDT and its proposed context of use can be relied upon to have a specific interpretation and application in drug development and regulatory review. So basically what this means is if you're doing a trial in people with lung cancer and you want to assess their symptoms, if there is a measure that's already gone through qualification for assessing lung cancer symptoms, you can use it. You don't have to, without any additional data collection or justification. The FDA will just accept it. So this is a great option as a starting point for selecting measures. There's only one qualification program. And as I said, once qualified, DDTs will be publicly available to be used in any drug development program for the qualified context of use. So right now, there are only 7 patient-reported outcome measures that have been qualified. One of them is in oncology, and that is the symptom assessment questionnaire for people with non-small cell lung cancer. So you can see this is measuring symptoms like cough, pain, dyspnea, fatigue, and appetite in adults with advanced non-small cell lung cancer. There are a number of other patient-reported outcome measures that are in the process of getting qualified. You can see there is a measure of physical function for adults with solid tumors or hematologic malignancies. So that's going to cover a huge number of patients. There are measures of pain intensity, interference, and physical function for children and adults. Disease-related symptoms in renal cell carcinoma, and then another symptom severity measure in adults with small cell. So let me switch gears and share some examples of recent research using patient-reported outcome measures. I'll start with this TAILOR-X trial. This is a trial of taking women with a breast cancer diagnosis and randomizing them either to receive endocrine therapy alone or chemoendocrine therapy. And that randomization is based on a number of factors, including their oncotype score. And so this presented an opportunity to understand the unique contribution of chemotherapy to cognitive changes or chemo brain that patients often complain of. And what we see in this trial, in the graph on the left, time is on the x-axis, and on the y-axis is a change score. So this is a change in cognitive impairment or cognitive function. So down is bad. The blue line is the arm with endocrine therapy alone, and the red line is for chemoendocrine therapy. And what you can see is at 3 months, the women who were on chemoendocrine therapy had significantly worse cognitive impairment than women that were on endocrine therapy alone. But then if you look starting at month 12 and onward, the 2 interventions are about the same. Both are reporting cognitive dysfunction, cognitive impairment. And even at 3 years post the initiation of treatment, they're not back at a pre-diagnosis, pre-treatment level. So they're experiencing cognitive impairment, and it's continuing over time. This study also had a number of other findings related to symptoms. If we think about fatigue, one of the most commonly disruptive symptoms that patients experience, this study found that chemotherapy was associated with greater fatigue and more endocrine symptoms in that acute period of treatment. than the endocrine therapy alone, and that the fatigue was comparable in both arms at follow-up and persisted over time. In another evaluation of this data, it was identified that younger women were more likely to discontinue endocrine therapy, and their health-related quality of life and a history of depression were predictive of who was at greater risk for discontinuing. And then finally, women who were uninsured or underinsured had a higher rate of treatment non-adherence, and a neighborhood deprivation index was associated with non-adherence. So in this study, it identified a number of different subgroups experiencing different kinds of symptoms, the timeline for those symptoms, and factors that you could intervene on earlier to help improve adherence to endocrine therapy. This is a second study, the ASSURE study. This is the study design showing that folks were randomized to one of 3 arms, excuse me, 2 drugs to treat renal cell carcinoma and a placebo. In this graph, we're looking at each of those arms, the 2 drugs and placebo, looking at fatigue scores over time. And what you see is that all 3 groups experienced fatigue, worsening fatigue, by week 10. Everybody had an increase in fatigue, reduction in energy by week 10, and it stayed that way through week 22. This study also looked at, well, how does that patient's report of fatigue compare with a clinician's report of fatigue? So the CTCAE adverse event scale is a way for clinicians to report on adverse events related to cancer treatment. This graph shows patients' reports of fatigue on a self-report measure on the FACIT fatigue scale compared to the CTCAE fatigue grade provided by their clinician. And so what you see is for this first group, 0, these are patients who reported no fatigue. I don't know who they are, but they reported no fatigue. Group 1 are folks whose fatigue was improved with rest, to fatigue not improved with rest and starting to be disruptive in some activities. And then 3, fatigue that's not improved with rest and it's interfering with self-care ADLs. What you note, however, is that 25% of patients who their clinicians said they have no fatigue, they're in this 0 group, are reporting clinically significant fatigue. So what patients are experiencing and reporting is different from what clinicians are reporting. So patients are providing some unique information. This is another study with breast cancer patients comparing 2 aromatase inhibitors in postmenopausal women. And the patient-reported outcome measure of interest was a report of endocrine symptoms. These were followed over 2 years. And these were null findings. Both groups looked the same in terms of endocrine symptoms, which is actually really helpful information to know that neither one of these is superior than the other in minimizing endocrine symptoms. And those symptoms were worsening by month 3 and then stayed pretty consistent over time. Ethan Bosch published a very provocative study in 2016 and then a follow-up in 2019. This was a study with 766 patients with cancer, and they reported on the patient version of that CTCAE, where they were reporting on important symptoms like loss of appetite, constipation, cough, diarrhea, etc. And what this team found, on the left, you see the first bar represents usual care. The second bar represents those patients that were in this intervention arm where they're reporting every week on their symptoms. The top, that blue section of the band, represents patients that experienced any change. And you can see that those in the intervention were more more of them had improved quality of life compared to treatment as usual. The 2 bars on the right represent changes by more than 6 points. So that means these are really meaningful changes. This isn't just a small statistically, but not meaningful change. And you still see that. So patients who are in this intervention are, more of them are reporting improved quality of life. The patients who were receiving usual care had more ER visits than patients who were participating in this weekly symptom assessment. And then at 2 years in an intent to treat analysis, they found an actual survival benefit that patients in the weekly monitoring group at 2 years had a higher survival probability. So in summary, patient-reported outcome measures can quantify the impact of treatment on important domains of health. Patient-reported outcome measures can clarify the timeline for that impact. That's really helpful for patient education and setting expectations, as well as identifying intervention time points. Patient-reported outcome measures can predict early discontinuation and non-adherence for some treatments, and they provide information that is not captured by patient report. So there are lots of reasons to include patient-reported outcome measures in your research, and there are a lot of resources to help you do that. So the Outcomes Measurement and Survey Core is one of the shared cores here at the Cancer Center. Our mission at the OMSC is to provide consultation and support for research that involves collecting, analyzing, and interpreting self-report data. We provide guidance on the best ways to measure outcomes that are derived by self-report and serve as a central resource for state-of-the-science instruments and measurement methods. We also offer in-house support for translation, collection, and analysis of outcomes and survey data. The costs for that, a brief consultation, so for example, if you want to include a patient-reported outcome measure in a grant that you're submitting, the costs for that are covered by the Cancer Center as part of the shared resource core. If you need ongoing support, you can contract for additional time. Such as if you want to conduct and analyze qualitative interviews to help identify what are those outcomes that are important to patients. This is the OMSC team. I'm the director. Other faculty include David Sella, Jen Lai, Devin Pipert, Kippy Webster, and Bettina Yanez. And Sarah Buono serves as our coordinator. If you email omsc@northwestern.edu, you will get to Sarah first, and she'll route you to the right person. Our areas of expertise start with survey methodology. So question wording, formatting, sampling, timing, respondent and staff burden, methods of assessment, and training interviewers are all included in that survey methodology area. We have expertise in qualitative research, including focus groups, cognitive interviews, linguistic translation, and adaptation of existing measures. We are an internationally recognized center of excellence for patient-reported outcome measures. That includes selecting development of questionnaires about health status, symptom burden, health-related quality of life, and treatment satisfaction. And we also have expertise in psychometrics, which include reliability, validity, dimensionality, item response theory, scoring algorithms, measurement bias, and sensitivity to change, all related to patient-reported or even clinician-reported measures. This is the website, and I want to point out we have a section on the website called Outcomes Measurement Resources that provides a curated list of some really exceptional resources if you want to learn more on your own. It starts with the ECOG Akron Pro Working Group that both Dave Sella and Devin Pipert in the OMSC helped design and are part of. It includes a reference library and a number of training resources. These materials are available to ECOG Akron members. If you really want to get to them, you could email the OMSC and Devin could probably help you out. A second resource is the Patient-Reported Outcomes Tools Engaging Users and Stakeholders, or Proteus. Proteus has the aim of promoting systematic use of methodologic tools developed to optimize the design, analysis, reporting, and interpretation of PROs in clinical trials and in clinical practice, although their strength, I think, is way more in clinical trials. This group was initially funded by a PCORI grant and then also had some Genentech funding, and is a consortium of lots of diverse groups, patients, clinicians, researchers, regulatory groups, and represents folks within the United States, but also outside of the United States. The tools focus in two areas, the first being study design. So the topics that they cover include writing grants, developing protocols, selecting measures, and analyzing data. And one thing that I like that they do really well is they provide resources in a lot of different formats, kind of depending on what you need and what you can actually apply. So this would be an example of some of the articles they include, recommendations for including PRO endpoints in grant applications, and then guidelines for inclusion of PROs in clinical trials. So if you like to read, there are great articles that they've identified. That one article then is also available as an on-demand lecture with the senior author and lead author. And then they also have a checklist. So you can use that as you're reviewing your own protocol to make sure you're adhering to these guidelines that have been developed by a consensus process. The second set of tools is related to study reporting, and this focuses on reporting data, displaying results, and applying findings. And again, lots of different modes of how that information is delivered. This is an example of a paper led by Claire Snyder about how to graphically display PRO data results. And then that information is also available in a checklist, which I think is a little easier to directly apply to work you're doing. A third tool is ePROs in clinical care. This was, I believe, an AHRQ grant and another consensus process. The ePROs in clinical care really focuses on electronic, that's your E, collection of patient-reported outcome measures in clinical care, so in regular routine clinical practice. So less about research and more about in clinical care, but the implementation issues are often the same. The resources that ePROs provide are on governance. And so here at Northwestern, for example, there is the NM Pro Governance Steering Committee that is overseeing all of the implementation of PROs across the healthcare system. Integration related to technology, how do you integrate PROs into Epic or other data collection systems? And then reporting, so some overlap with the resources Proteus provides as well on best practices for data visualization or how to report PRO data. And then the last resource that I'll highlight is our healthmeasures.net. This is led by our team at Northwestern in Medical Social Sciences. Health Measures is the primary dissemination site for PROMIS measures, which are widely used in cancer as well as other chronic conditions. So you can access PROMIS measures on this site. And then there's also a lot of guidance here as well for measure selection and implementation, score interpretation for PROMIS, and then some introduction to measurement science information as well. So in conclusion, patient-reported outcomes are critical to include in cancer research. There are an increasing number of resources to facilitate implementation and use, and you don't have to navigate this alone. So if you are interested, I think one of the best things you can do is contact the OMSC and schedule a brief consult with one of us who can help guide you into how to include patient-reported outcome measures in your work or survey data in your work as well. So with that, I'd like to acknowledge the OMSC team that helped contribute slides, as well as Lynn Wagner, who shared some of her clinical trial slides. The OMSC website or email address is here, omsc@northwestern.edu, and I would encourage you to reach out and contact us. With that, I would be happy to answer any questions. Yeah. Okay, so the question is, for the fatigue score, the patient-reported outcome score is different than the clinician-reported score. How did that happen? It happened because those two people have different sources of information. They have different expectations. They have different ranges of what's normal. And so they have different information. So I would say in a clinical trial of fatigue, a patient report is the gold standard. But a clinician report can also provide additional information.
Report that score without talking to the patient, because like after discussion, it scores them based on their their own measure.
Yeah, so how did the clinician create that score? I am sure the clinician talked with the patient. But I'm not sure. I would defer to clinicians on how they rate on that ECOG form. The other thing too is that CTCAE measure, it's a single item. And so it's a pretty gross measure of fatigue. The FACET fatigue measure is multiple items, and it asks a number of questions about different aspects of fatigue. And so you're just naturally going to get a more reliable and nuanced piece of information from that longer measure that includes more than this. You know, if your option is no fatigue or fatigue that's immediately disruptive, that could leave a lot in there.
The same tool, we might be able to close that, right?
If we use the same tool, we might be able to close that gap, but I would still say the patient is the best source of information on how their fatigue is impacting their life. What other questions could I answer?
Thank you.
Hey, you're welcome. Thanks, everyone.